Good afternoon. This is Dr. Negar Motagheni from Channel 1 TV. Today's program has two main parts. The first part is a very special guest, star scientist, Dr. Gary J, to shed more light on the headaches. And the second part will be most novel information on COVID-19 findings. با درود و سلام خدمت همه بینندگان عزیز تلویزیون جهانی کانال 1. من دکتر نگار مطیقنی برنامه امروز طلوع رو خدمت شما تقدیم می‌دارم. برنامه امروز دو قسمت داره. یک دانشمند بسیار معروف در زمینه پین، درد و سردرد در خدمت شما خواهیم بود. قسمت دوم برنامه کووید و یافته‌های جدید در مورد کووید رو اطلاع رسانی خواهیم کرد. همینطور خلاصه ای از مصاحبه انگلیسی ما هم در این برنامه هم در برنامه‌های آینده خدمتتون تقدیم خواهد شد. For the first part, we have a special guest, the star scientist Dr. Gary J, to shed more light on headaches. Up to 75% of adults worldwide have had a headache in the past year. Headaches are a major cause of absenteeism from work and school. For some people, continually battling headaches can lead to feeling anxious and depressed. I'm so honored and thrilled to introduce Dr. Gary J from University of Chapel Hill from beautiful North Carolina. Dr. Gary J is a clinical professor of neurology and head of the Division of Headache and Pain at the University of North Carolina, Chapel Hill. Dr. Gary J specialized in pain and headache for over 40 years. Dr. Gary J was one of 30 founders of the American Academy of Pain Medicine in 1983. One of 8 founders of the American Academy of Management in 1988. Dr. Gary J had been president of the Florida Academy of Pain Medicine, the Eastern Pain Association, and the American Academy of Pain Management. Dr. Gary J in 1981 was the founder and first president of the South California Pain Society. Dr. Gary J had 5 books published and over 180 journal articles, book chapters, and more. Dr. Gary J given over 500 requested lectures around the world on headache, pain of all types, and MTBI. Also, having taken a sabbatical from full-time work, just doing HA for patients internationally, worked in pharma with his last position as a chief medical officer, bringing one drug through the FDA. And he has been CMO of several other pharmas and participated in 4 NDAs and 6 INDs. Dr. Gary J, I am so honored for this interview. Thank you so much for giving your time and accepting my invitation.
It's my pleasure. Thank you for inviting me.
Dr. Gary J, worldwide headache is really common. Would you please let us and our audiences to know a brief and bold summary of the etiology, different kind of headaches, symptoms, and the most novel treatments and approach?
Well, as you noted, a study showed that over 3/4 of the people in the world suffered headache last year, and it was mostly what's called tension type, or what used to be called muscle contraction headache. This is different, obviously, than migraine. In the United States, there is at least 40 million migraineurs, and we feel that that's probably 50% of the number of patients with migraine that are out in the community. And the primary headache disorders, those are 2, migraine with and without aura, chronic tension type or episodic tension type headache, cluster headache, which is now known as a trigeminal autonomic cephalalgia is the other. And this is part and parcel as we get more and more information into what causes headaches and what we can do to treat them. We've had a paradigm shift in the last 2 years in treating migraine. We used to use to abort migraine triptans, and now we have, for prevention and to enable us to abort a migraine, the CGRP or calcitonin gene receptor antagonists to stop migraine or prevent migraine. And this is just in the last 2 years. It's a major paradigm shift in the treatment of headache.
Wonderful. Would you please categorize different type of headaches, compare with each other? Let's say cluster headache with migraine and other types of headaches.
Migraine is a neurovascular problem, and it's in the brain. It begins in the brain, and basically there's a give and take between the neurons and the vascular system, the blood vessels, the arteries and the veins in the meninges, particularly, as well as changes in the blood flow in the brain. Whereas chronic tension type headache is what we used to call chronic or acute or episodic muscle contraction headache, which is mostly stress related, whereas migraine is genetic. Over 80% of people with migraine have family members with migraine. That's not necessarily true at all with tension type headache patients. And 8% of women in the United States have migraine, 6% of men, whereas with cluster headache, which is also vascular in nature, but also a trigeminal nerve, a fifth cranial nerve, autonomic headache or cephalalgia, there's 10. It's almost exactly the opposite. It's a rarer headache, much rarer headache, and it's a male predominant headache, whereas in migraine, as I said, 18% of women in this country have migraine and 6% of men have migraine. Cluster headache is 10 to 1, men to women.
Interesting. What exacerbates cluster headaches? Are there new findings or potential therapeutics to target this kind of headache? As far as I have gathered information, this is one of the worst pain experiences worldwide.
You are absolutely correct. I've published that cluster headache is a suicide headache. It's a type of headache that doesn't last longer than 3 hours. Typically, it's 45 minutes to 3 hours. The pain is immediate at 10 plus over 10 if you listen to patients. And as I've traveled around the country, patients have the same, when you ask them what the pain feels like, they'll all say something like this. It feels like there's someone in my head trying to push my eye out with a hot poker. These patients, when they have a headache, it's in the eye and or the temple. It's extremely painful, so painful that these patients can't sit or lie down. They pace, very agitated. They will strike their head against a wall, sometimes drawing blood, doing anything they can to try to divert the pain in some way, which unfortunately is not possible. We know we can stop the headache in 2 ways. Just like migraine, we can abort it, and we can use a triptan to abort it. Okay, the triptans are older drugs. They were started, the first one was in the late 80s, 1980s. That was sumatriptan. There's now 7 triptans, and the last one was in the 90s. The bottom line is you can abort that way, but what you want to try to do, because cluster headache patients can have 1 to 8 or 10 headaches a day. The average patient has 1 or 2. These headaches will be typically around the same time every day, because there's a chronobiological aspect, meaning there's a place in the brain in what's called the suprachiasmatic nucleus in the hypothalamus, which is involving the body's ability to tell time, if you will. And it enables us to sleep and tells us when to wake up, when to go to sleep, and so on. The issue is, if you have a cluster headache of 3, you'll have one every day while you're having that episode. If you have episodic cluster, there's 2 types of cluster headache. First type is episodic. That can be daily or every other day cluster headache for an average of 6 weeks on average, and it can go up to 12 weeks. And then the patient can have a remission period where they have no cluster headaches or a rare cluster headache for a year up to 4 or 5 years, and then they'll have another episodic cluster event. Then there is chronic cluster. It'll start and never. That's called primary chronic cluster. Secondary is when the patients have their episodic cluster with a, let's say, average 1 year time when they don't have headache, and that time without headache keeps getting shorter in between the cluster headache events, the episodic events, until you're having, essentially, you've gotten rid of the time the patient would not have a headache, so they have episodes that get closer and closer together until they're stuck having secondary chronic cluster headache. So you can abort these headaches using a triptan. One of the earliest things we used was oxygen. Oxygen, however, has become more difficult to obtain only because of insurance. And so we'd use a triptan to avoid it or to abort it. And then you want to prevent it. And there are 3 drugs that you can use typically to prevent cluster headache. And if a patient has a typical episodic cluster, I would see them about a month before, wean them up on the drugs they need to use to prevent cluster headache. And then at the end of their typical cluster period, I'd wait 2 weeks and then wean them off of those preventative drugs. And if they have, while they're taking the preventative drugs, a breakthrough, we can use a triptan, such as sumatriptan or any of the other 6, that can abort the headache, number 1. Number 2, there is the new CGRP receptor antagonists that is a humanized antibody. That is, you inject it every month, you self-inject it, the patient does. But there's one of them, galcanezumab, or this drug can be given at 300 milligrams a month, and it'll decrease about 50% of the episodic cluster headaches.
That's wonderful. Dr. Gary J., I do know that as a star scientist, you are involved in multiple pharmaceutical companies beside the academic work. Are there new hopes on the horizon for treatment of headaches like cluster headache and migraine?
People are always looking for new things. In cluster, the very newest thing is that galcanezumab, but there is something entirely different that's a non-drug where they can stimulate the vagus nerve in the neck, okay? And then there is another way where you can actually put a controller or something under the gum with a metal that goes down to the sphenopalatine ganglion, which is an autonomic bunch of nerves from the autonomic nervous system in the base over here. And basically, when a headache starts, they can put a controller on, turn on that device in the mouth, which will stop the headache most likely and most frequently. So these are new things that, again, are non-drug related. And some people like that because they are non-drug related. But drugs, fortunately, we have them that will work, are typically used. And insurance is one of the reasons that you can use more drug than the non-drug, the neuromodulation type issues.
Wonderful information. Thank you so much, Dr. Gary J. My other question goes to allodynia. Many of the people with headache experience this kind of effect. Would you please kindly shed more light on this?
Certainly. Allodynia is pain from non-painful stimuli. And it took years to realize migraine patients will not infrequently develop in the first 20 minutes of the migraine after it starts allodynia. And what happened, if you had migraine, for instance, and it hurt to comb your hair or brush your hair, that would be because you have allodynia or pain from non-painful stimulus in the scalp. But you can also have pain, allodynic pain, in the arm, in the hand, and other places that are called extracephalgic. That means not on the head. And why that is important, it's so important, is because you can abort, as we noted, a migraine headache using, again, you can abort it using a triptan or a CGRP receptor antagonist, or you can prevent it. But if you have allodynia, if you tried to use a CGRP, triptan, okay, it wouldn't work unless you also used a non-steroidal anti-inflammatory medication at the same time. Why that's important is the non-steroidal would stop the allodynia, and only then can the triptan work to stop the headache. If you can't stop the allodynia, you can't stop the headache. Triptan.
Perfect information. Does allodynia happens in cluster headache and tension headache too?
Typically, allodynia does not occur in tension headache. In cluster headache, you get autonomic signs and symptoms, but not allodynia specifically. The pain is very, very severe, as I've indicated, but you can have, with a cluster headache, autonomic nervous system changes. You'll have tearing on the side of the headache. The eye will become injected, it'll become red. The nose on the side, the nostril on the side of the headache will become stuffed, or it'll run. Okay, that's called rhinorrhea. But you don't have the type of allodynia that you see in migraine headache patients.
Wonderful. How is the genetic effect on creating such kind of symptoms?
As I noted to you, over 80% of migraineurs have a family history of migraine, which means you have approximately 20% that are sporadic patients. That is, there's no history of migraine in their immediate family that they are aware of. Okay, cluster patients, there are some families that do have cluster, but it's nowhere near the 80% mark. You're talking possibly 5 or less than 10% of cluster patients will have a family history. I should point out that the diagnosis of cluster headache is 1/3 of the patients, the new patients that I see, have a diagnosis of cluster headache. And after 5 years at University of North Carolina, I only have about a dozen true cluster patients. So what happens is people will take the idea of a severe headache and call it a cluster headache because, as you noted, doctor, that a cluster headache is the most severe type of headache that most people can experience. And so very simply, same works with migraine. A patient will come in and say, I have migraine headache. How do you know? I have headaches like the lady next door who has severe headaches that seem like mine. So you have people who have no clinical diagnosis, been giving themselves, or a doctor who doesn't specifically know, because they're not a headache specialist necessarily, how to diagnose a particular type of headache. So they will call it migraine when you do a very thorough analysis, it may not be.
Very impressive information. Thank you so much. Dr. Gary J., what about secondary headaches? Let's say using special kind of foods or medications or different environments? Could you please shed more light on those kind of headaches?
Okay, now I think let's get the nomenclature. Headaches that are secondary to triggers is, I believe, what you're asking about. There are, and that's different than secondary headaches. A secondary headache can occur from another disorder, such as fibromyalgia, or from a brain tumor can cause a headache secondarily. So you need to deal with the primary problem. But when you're dealing with triggers, there are, for instance, 5 or 6 things that are out of 143 food substances that are known to cause migraine. I have one patient who has a migraine if they have guacamole. Avocado gives them a headache. But the 6 most common things include aged sharp cheddar cheese, alcohol, exogenous estrogens, birth control pills, okay, MSG in Chinese food, nitrates and nitrites in processed foods, okay, and I think I missed one, did I say aged sharp cheddar cheese is the 6th. So those things are the most common food or substance triggers to migraine. Okay, some people, another very common trigger that is not a food substance, but for migraine, is a change in barometric pressure. If you have a nice sunny day and all of a sudden you're going to have a thunderstorm, the barometric level will change. It'll typically go down for that, and that will incite a migraine in susceptible migraineurs. Not all migraineurs have the same susceptibility to their triggers to their headaches.
Wonderful. While gathering information, I came across a new term which was ice cream-induced headache. I think possibly cold can be considered as one of the triggers, right?
You can have what's called a ice cream headache, which is not a true headache as such. If you have a lot of cold, if you have a freezing headache, if you will, it's anybody that has had a ice cream sundae or eats something very cold when they're very hot will have a severe pain in the back of their throat or in their sinus, it feels like, and this pain will go up into their head, and that's from the temperature difference. It's from the typically the fifth trigeminal nerve, cranial nerve, the 5th cranial nerve. But the idea of freezing headache is one thing, and that can occur to anybody in the right situation. But you have other types of headache. For instance, you can have what used to be called ice pick headache and is now primary stabbing headache, where patients will feel like, for instance, I just saw a very nice woman who has stabbing, can have one stab constantly over and over for a half hour, an hour, for all day. And it feels like they're being stabbed with a ice pick. Or you can have 3 stabs, 1, 2, 3, and a minute off. 1, 2, 3, and a minute off. Or you can go up to 5 stabs with a little time in between. Now, what makes that so interesting is there are a group of headaches, that's one of them, that are extremely susceptible to a very relatively innocuous drug called indomethacin, which is a non-steroidal anti-inflammatory. It's one of the strongest non-steroidals. You could not get this drug over the counter. It would have to be prescribed. But the point is, if you have stabbing headache, if you have cough headache, some people will have what's called a cough headache. They'll cough and they'll have severe pain in their head. You have patients that can have post-exertional headache, where they'll work out, okay, in the gym and develop a severe headache that can last 1 to 2 hours. And you can even have patients who have post-orgasmic headache, okay? And the treatment for all those headaches is indomethacin. And if you know, for instance, that I'm going to go work out now and I always get a headache 2 hours later, you can take the indomethacin prophylactically to prevent the headache. So you want to try to prevent a headache like that rather than try to treat it. It's harder to treat it. It's easier to prevent it.
Wonderful. What about smoking, Dr. Gary J? Could it be one of the triggers?
Smoking by itself is not one of the triggers for headache, but smoking, of course, will affect the lungs, which will create problems with breathing. Decreased oxygen can do that. A very obvious way of looking at that is people who have obstructive sleep apnea, where you have people who snore at night and their spouse or their significant other will notice that while they snore at night, they'll miss a couple of snores every now and then. And so they should be tested, because what happens is if they miss snores, they're not breathing during that time. That's apnea. That's the lack of oxygen because they're not breathing. And what happens is in these patients with obstructive sleep apnea, they have decreased oxygen, which dilates the blood vessels in the head, which causes headache that's there when the patients wake up in the morning. That's why the treatment for that is CPAP, or oxygen, a mask that these folk will use while they're sleeping. And it'll prevent the type of headache that's there when they wake up every day.
Fantastic information, Dr. J. Last not the least, what headache symptoms requires immediate attention?
There is a type of headache called a thunderclap headache, okay? And this is a headache that typically within 5 or 6 minutes can cause unconsciousness. And you see this in patients with an aneurysm that may break, or so they'll have bleeding in the brain, okay? And that's the sort of issue that needs to be taken care of as fast as humanly possible. And the only place to do that is in the hospital.
Wonderful, phenomenal information. Again, so many thanks, Dr. Gary J, for accepting my invitation. I greatly appreciate your time and giving me this honor and having you in Global Channel 1 TV. Thank you so much and looking forward meeting you again. Thank you.
My pleasure. Thank you, Doctor.
با سلام مجدد خدمت همه بینندگان عزیز تلویزیون جهانی کانال 1. همونطور که مشاهده فرمودین ما مصاحبه‌ای داشتیم با دکتر گری جی از دانشگاه چپل هیل ایالت زیبای نورث کارولاینا. آقای دکتر گری جی یکی از دیستینگویش ترین صاحب نظرات در زمینه پین و درمانهای سردرد و تشخیصهای سردرد هستند. خیلی خلاصه اگه بخوایم اشاره بکنیم، سردرد 75% مردم دنیا رو در مراحل زمانی مختلف تحت تاثیر قرار میده و به دو دسته مختلف تشکیل میده: سردردهای اولیه که معمولا زمینه ژنتیکی دارن و سردردهای ثانویه که به دنبال داروهای خاص یا به عنوان تروما یا اختلالات عروقی و یا بیماری‌های دیگه میتونن رخ بدن. همینطور تریگرهای سردرد رو ایشون اشاره کردن که عللی مثل پنیر کهنه، شراب و به عنوان تریگری برای حتی فکر کردن به سویساید و خودکشی ذکر شده. ما ورد بای ورد کلمه به کلمه این مصاحبه رو در برنامه آینده خلاصش رو خدمتتون خواهیم گفت. به خاطر کمبود وقت الان میریم سراغ تازه ترین یافته های ما در مورد کووید در گوشه کنار دنیا. از اتاق فرمان خواهش میکنم اسلاید اول رو. طبق آخرین گزارشات رسیده کووید ویروس توتال کانفرمد کیس 192.5 میلیون نفر هست. توتال دسی که گزارش شده 4.1 میلیون هست و نیو کیس ها 575.279 گزارش شده. این در حالیه که تعداد نیو دس به 8765 رسیده. از لحاظ آمار واکسیناسیون اسلاید بعدی لطفاً. Per 100 people worldwide به ازای هر 100 نفر مردم آمار جهانی واکسیناسیون به 48.6 رسیده در حال حاضر. این رقم برای کشور چین 104.5، برای کشور هند 30.3، ایالات متحده آمریکا 101.6 و برای انگلستان 124.3 هست. اسلاید بعدی لطفا. این رقم برای کشور ژاپن 58.5، برای کشور فرانسه 99.5، کشور ترکیه 76.7 و برای کشور کانادا 124 هست. این در حالیه که برای کشور روسیه 38.3 گزارش شده. اسلاید بعدی لطفا. کشور کره جنوبی 43.6، امارات متحده عربی 166.3، کشور اسرائیل 127.5. اسلاید بعدی لطفا. سوئد 99.5 و کشور ایران 9.7 هست. اسلاید بعدی لطفا. از لحاظ شیوع بالاترین کیس ها در قاره ها و کشورهای مختلف، یوکی در قاره اروپا همچنان بالاترین آمار رو داره. بعد از انگلستان کشورهای اسپانیا، روسیه و فرانسه قرار دارن. اسلاید بعدی لطفا. برای کشور میدل ایست خاورمیانه ایران بالاترین آمار رو داره. بعد از اون عراق، امارات متحده عربی و عربستان سعودی قرار دارن. این در حالیه که کرونا در ایران در موج 5 خودش قرار داره و گزارش شده که تعداد بستری ها و مرگ و میرها میتونیم بیاین داخل افزایش پیدا کرده و قله 5 کرونا میتونیم بیاین داخل اتاق فرمان. قله 5 کرونا گزارش شده که هنوز به پیک خودش نرسیده. این در حالی که آمار بستری ها حتی طی یک روز آمارش خیلی بالایی و گزارش شده که آمار مرگ و میر خیلی بیشتر از اون چیزیه که گزارش شده. حتی در یک سری بیمارستان ها از جمله استان گلستان طبق گزارشات کمبود تخت های بیمارستانی و ICU هست و بیماران در کف راهروها در حال تمرکز هستن که بتونن اینا رو مواظبت بکنن ازشون. و همینطور گفته شده که تعداد تعطیلی ها رو میخوان افزایش بدن، شاید بتونن یه مقدار کرونا رو تحت تاثیر قرار بدن، کنترلش رو. 232 شهر در ایران در حال حاضر وضعیت قرمز درشون ایجاد شده. واکسن های روسی و چینی گزارش شده که افکتیو نبودن، مؤثر نبودن. و در مورد واکسن سینوفارم گزارش شده که بیش از نیمی از سالمندانی که واکسن سینوفارم رو گرفتن متاسفانه مجدداً مبتلا به کرونا شدن. اسلاید آخر لطفاً. اسلاید بعدی. خب میتونیم بیاین داخل. یک گزارشی که اسلایدش رو در حال حاضر جلسه آینده نشونتون خواهیم داد این هست که واکسن کووید تقاضا و دیمند بیشتری داره در کشورهایی که با کمبودش مواجهن. طبق مقاله‌ای که در مجله معتبر پزشکی نیچر منتشر شده، گفته شده در کشورهای اروپایی و کشورهایی مثل ایالات متحده آمریکا که واکسن در حد کافی وجود داره، میزان دیمندش محدودتر هست در مقایسه با کشورهایی که متاسفانه به این واکسن دسترسی ندارن و میزان دیمند خیلی بالاتر هست. همینطور یک جلسه روز پنجشنبه ساعت 11 AM تا 4 PM به وقت شرق آمریکا قرار بود با ادوایزورهای CDC و FDA برگزار بشه برای اینکه تصمیم بگیرن در مورد شات بوستر، دوز سوم، به خصوص در افراد ایمونوساپرسیو و همینطور در مورد عارضه جدید گیانباره که در واکسن زده ها گزارش شده. اینها میخواستن تصمیم گیری بکنن، دیتاها رو بررسی بکنن که هر موقع که به نتایج نهایی برسه ما حتما اینا رو خدمت شما تقدیم خواهیم کرد. خیلی ممنون که بیننده برنامه ما هستید. برنامه ما هر سه شنبه ساعت 6 بعد از ظهر به وقت غرب آمریکا مطابق با 5:30 صبح به وقت ایران پخش میشه و ما تازه ترین یافته ها و درمان ها و تکنولوژی های پزشکی رو خدمتتون تقدیم میکنیم. تا برنامه آینده، روز و روزگار خوش.